session. So I'm just going to say I'm excited to be here today. So I chair the Texas Diabetes Council here in our state, and just excited to dive into this discussion.
Very good.
Yes, and my name is Ginés from Dia de la Mujer Latina. And again, thank you so much for the invitation. I look forward to the conversation. I am going to have to turn off um, because of the bandwidth and the issues that we've had this morning. I'm going to have to turn off the video, but you're going to be hearing a lot from me.
Very good. Thank you so much. And again, welcome, ladies. Thank you for being here. Our first question as we get started, and this question is to the both of you. What are the most important things that can be done to address these disparities in healthcare overall? And then a part two to that would be, how are your organizations helping? What kinds of programs or research do you guys provide? And either one, you can jump in there.
I'll start off, and that's a great question. Technology has brought the world, together, made it much smaller. So one of the key ways that I see in helping address these disparities in healthcare is we need more online campaigns that reach all age groups, whether we're looking at the young ones, we're looking at the middle or the elderly. Having these online campaigns is really crucial. And in our organization at the Texas Diabetes Council, we are supported administratively by DSHS, and I'm not sure whether people know that. And DSHS is the Texas State Department of State. And they have done a phenomenal job in doing online campaigns, like we said, a diverse audience of that. Also, this past year, due to the pandemic, we've seen a lot of governmental increase in grant programs that addresses specific health concerns to close that gap of disparities within our communities. So that's one key thing. And also another thing that the council has done for years is partnership, leveraging the use of partnership. I believe this summit is one of that, the Health Tech Summit. It's leveraging partnership that people that don't know about the council, they get to know about this, by watching this. So those are one of the ways that, we're working in the council to close these gaps.
And this is Venus. I totally agree. I think first and foremost, as a community advocate, we must first address the social determinants of health and how to engage our grassroots and faith-based community organizations in the planning and execution of this effort. It can't be just this group of people in an ivory tower thinking of ways that they can reach our community and have all our issues erased. That's not going to happen. We really need to address each of those social determinants of health and then have a plan of action with engaging our grassroots organization and faith-based. Secondly, two words, commitment versus convenience. There needs to be a solid commitment to addressing the system and cultural barriers that we see in our community, especially from, throughout the continuum of care and their care coordination for their diabetes. This means that we must encourage culturally competence training for all public health providers to better understand the whole person, because you can't just treat one condition, you need to treat the whole person. And lastly, we need to have an open discussion on the role of racism as the root cause of health disparities. And so what we have done as an organization since 1997 is that we've been hosting health fiestas. And most of our health fiestas have, brought in some of these activities and screening. I think I'm going to try to get our health fiestas had some of those diabetes screening, hypertension screening, breast and cervical cancer screening. So we brought these to the community in several pockets of our community where it was very easy for them to get there. So transportation wasn't going to be an issue. But there's some people who were really learned for the first time that they had an issue with their high glucose. They didn't even know that was happening in there. And so for this reason, we set up a patient navigation program called the Intercultural Center for Health Research and Wellness. And what we have done is really not only worked with the patient from the moment that they got diagnosed, but work with them through the follow-up care. So what we did is we started with and I'm so sorry about the coughing. We started with our training of promotores and community health workers. That has been an invaluable service to our community because they have been trained, they have been certified, but more importantly, a lot of them have lived some of those system and cultural barriers. So they have been very, um, they know how to reach our community. And we've been doing this since 1997. So of course, when COVID hit, we were already on top of it. But as we've always said, disparities hit and they don't call us until the last minute, until they thought of all these plans and it doesn't work, something's not working, and then they reach the community partners to help out, but then it's a day late and a dollar short.
Yeah. Wow, very good. Thank you for those responses. Now, speaking about health literacy, what would you guys think? How much of it is it a challenge to the Black and Latino communities, health literacy?
I believe it's a big, big challenge, almost like the elephant in the room within our communities. Kaiser Permanente did a study not too long ago, and it actually showed that not just for our communities, Latino or Blacks, but Americans in general, there was a 36% of Americans with actual health literacy. What does that tell us? That tells us that it's a field that the terms, the terminologies are intimidating to people, not just Blacks or Latinos, everyone. Um, then, when you look at our communities, that's compounded by history, the fear that, oh, maybe, when I go, something is going to happen. They're going to say I have something. They're going to use me as a lab rat, and, all those kind of things. We have all that. So when we look at health literacy, the ability to take health information, appropriate it and use it for our good, we see that it's a big, big obstacle within our communities. Now, I always like to address, we just don't talk about the problem, but how do we move this thing? How do we cut down this elephant piece by piece, or how do we remove this mountain, right, for our communities? I think we have a lot of work to do. It's not just for healthcare providers, because really our healthcare providers, they're stretched thin in the past 18 months. We've seen that. And they're doing their very best. So what that tells us is we need more people coming together to address this, not just healthcare providers. And for a long time, we've left every single bit of it to healthcare providers. That if our healthcare providers, if I can just go to the doctor, they tell me this and I do this, and that's fine. But we see that our communities are being left behind. And if the pandemic taught us anything, it enhanced the disparities that was already in existence in every aspect of our system in all our communities. So what do we do? I think we need lots and lots of educational sessions, wherever that may be within our communities, to break down simple health information. As simple as if you have a patient that goes into their PCP and they get the first diagnosis, maybe that's the first time they've done their blood work or annual check, and that's the first diagnosis they have. They have no idea even what their blood sugar means. They have no idea what insulin means. They have no idea how their body organs function and how all those come together. They have no idea of that. So health literacy is just not in our own communities. It's that elephant in the room that we need to address, and educational sessions anywhere possible is one of those ways to make sure. And for our communities, that language is a big barrier. Having a provider, interpreter, or translation services is key, so that each patient can understand the health information that is being shared in their own native language, one-on-one. And they can address that and say, okay, that's what that means. It costs a lot of money to do all these things, of course, we know that. So that's the key thing, on the big challenge health literacy is in our communities.
And I agree. I think on top of that, we have to look at two specific issues when it comes to health literacy and health care. And one of them is underdiagnosed and then misdiagnosed. So an underdiagnosed is doctors may not fully understand the complete picture if the patient is giving them incomplete fragments of information because they may have missed something in the asking because they don't know how to ask. And many people in our community are afraid to ask. There's that communication piece that we have to look at, and how can we really tailor a better messaging plan for our community so they can feel confident to be asking these questions. And the doctors should be asking also some of these important questions. And patients may not completely understand the information that's in these medical forms or even the HIPAA form or any of these informed consent because, like the doctor said, some of these are translated literally. So a lot of the information is not appropriate for many of us in our Latino community. I mean, we're like scratching our head. Where do they think this word came from? And so the Spanish translation is a real issue. It's not culturally and linguistically appropriate for our community. And then also the understanding about the medications that are provided to them. You know, seeing the word take once a day and think that once ONCE means once, 11 in Spanish. I mean, these are the kinds of things that we have to be really cognizant about the fact that our community may not understand that. So really take that time to have that kind of conversation before you hand out a prescription. And again, going back to the misdiagnosed, language differences, colloquialism, all of these acronyms that we seem to just keep throwing out to our community thinking that they understand. These factors may mislead physicians from the proper diagnosis, which can cause undue pain and suffering and again, mistrust. So I agree.
Very good dialogue and conversation. I think about the side of generational type of populations that we deal with in health literacy, and I think we all kind of touched on it in regards to the a culture. So when we think of the culture that we're in, and it's kind of sometimes given a blanket diagnosis, everyone fits in the same boat. But culturally, when you think of the older people or the elderly generation or population, you think about how you are trained. Just listen to the doctor, whatever they say, that's what goes. And we don't ask questions, even though we don't understand the big language and the medical terminology. So really getting into communities and, promoting confidence in those terms and breaking those down. So I appreciate that piece about the culture side that comes into working with different populations. So very good. Let's move on to our next question. This is good information. How and why does food play such an outsized role in the Black and Latino communities?
Food is everything, right?
Yes.
Not just, our communities, but, food in general brings people together, right?
Yes.
It means a fellowship. We're getting ready for the holidays right now. Next week is Thanksgiving. I can't even believe that.
I
And
know.
very soon, next month, we have Christmas. So food does play a major, major, major role. And for what we're talking about today, diabetes, food is the avenue through which that happens, right? People eat food, and that food is transferred into energy into the body, right? And then when that doesn't happen, the pancreas doesn't function to give the indicator to the insulin that, well, you need to pass this energy of this food that has been eaten into the bloodstream. We have a problem, right? We have diabetes. So in most of our communities, understanding the nutritional value of food is something that we're yet to really, really get good at. However, you'll find out that for a lot of our Latino and African American communities, they are food deserts. They are food deserts because most of the places are in distressed, underserved communities. I had a little chance to listen in the prior presentation, and they were talking about underserved communities. Yes, those in our underserved communities, I don't know how many people have taken a drive. Over the summer, my husband and I took a drive to one of the distressed locations within our area here in the DFW area. We did a 3-mile round drive. And within that 3-mile round drive, there was not one single grocery store. One single grocery store. However, we counted so many pawn shops, we counted so many liquor stores, we counted convenience stores. We did not even find a bank because most banks do not want to invest in distressed communities. So, what are we left with? We're left with convenience store where our children will go to the store, pick up a Cheetos, and pick up maybe a Dr. Pepper. Nothing wrong with that. However, if that is the lifestyle or the consistent meal that is being eaten, of course, we're going to see what we're discussing today, diabetes. So, in our community, food is everything. We need investments, those that will take that risk and invest within our communities. You go to other communities, suburb areas, you don't even have to drive a 3 mile radius. Just drive 1 mile radius. You will find at least 5 or 3 different grocery stores, fully stocked. So that tells us something. This is 2021. It tells us that we still have a lot of work to do. So access to healthy foods is every single thing in maintaining a healthy lifestyle. And if we do have patients or people already with diabetes, the ability to be able to healthily manage their diabetes is crucial and is linked to healthy food.
Mm-hmm. Mm-hmm.
And I agree. In some Latino cultures, food can be high in fat and calories. We tend to fry a lot of our food, and I grew up with everything was fried. And family celebrations, as you bring up, may involve social pressures to overeat. And if you turn down the food, it'll be seen as impolite to some cultures, and so you eat. And but we have to also look at the way that food has it's right, exactly what you're saying. Food deserts play an important role in some of the issues that our communities are suffering from. And this is another part of that social determinant of health that I've been really concerned about, is the fact that we tend to blame the victim or blame the patient. Oh, they shouldn't be eating so much, or they should be doing this, or they should be doing that. When in fact, as you pointed out, the food deserts, the grocery stores that are there, are the prices are really incredibly high
Yeah,
compared
yeah.
to some of these others. So we have to look at those things and see, if you have a family with 5 children, you have to feed them. How are you
Mm-hmm.
going to really feed them? Well, maybe it's a
Mm-hmm.
lot easier to just go and get these hot dogs that are like a dozen, and just use something like that that has got high in fat and of course processed food. I can't say enough about the throes of processed food.
That was the exact point I was going to think that came to mind. Is it is expensive to eat healthy.
Yes,
So what are we doing for our communities that have to feed a family of five and on subsidized assistance and those kind of things? How do we not only make it available for them, however, educate them on the types of foods that can stretch as they're trying to stay within a budget or so. So very good point there. Now, this question is for Venus. How effective do you think Promotores are at improving Latino community health?
So, promotores is a Spanish word for really community health workers. That's their task, is to really promote health and wellness in their community. So, in here in the state of Texas, we have a unique ability to train and certify and have it all blessed by the state. The training has to be evaluated when we put together any kind of training. We were certified by the state of Texas in 2009 to promote this training program that we have modeled under what we call the MIND framework. MINE. M is we're going to teach them how to motivate our community to get early detection screening. The I stands for informing them in a culturally and linguistically appropriate manner about health and wellness, and also about the resources. And talk about resources, the N, navigating them to those resources, but navigating them through the complex healthcare system that we have. And E is the education. I can't stress enough, and I think it's been brought up already. health literacy. I mean, we've got to bring that information in a level that they can understand it. And that's the beauty of our promotores and community health workers. They've been trained on how to communicate. We have 8 core competencies. So it's communication, interpersonal skills, advocacy skills, service coordination skills, capacity building skills, organization skills, teaching, and then knowledge base. Those core competencies are key in giving the promotora and the community health worker confidence in having those type of discussions. And again, that's why I think promotores and community health workers are finally getting the recognition that they deserve, because all through these years, we've always knew for diabetes, HIV, we always can rely on cancer. We can always rely on the promotora and community health worker because they know how to relate to the community. And again, some of them have lived those system and cultural barriers, so they totally understand.
Very good. Now, Dr. Obamehinti, sorry. How does Texas Diabetes Council influence the Texas legislator and Texas HHC in addressing the overall care of the diabetes population in Texas? That's a mouthful.
It is a mouthful. That's a great question. But let me begin by saying Texas Diabetes Council does not influence, because wording does matter. And I want people to understand what we do and how we do what we do. So we do not influence the legislature. However, we do advise the legislature. So I want people to get that notion of what the work entails. And our advice comes in what we call the state plan. So every other odd number of years, the council puts together a state plan. Before then, we do a statewide needs assessment as it addresses the needs of people with diabetes or pre-diabetes in Texas. And like I said earlier, we are so fortunate to have the administrative support and covering of DSHS. So they really do a lot of those heavy lifting for us. And for those audience members watching, that's a state governmental agency. So how that work happens after we do our needs assessment across the state, all those now are then put together and we come and summarize some major priorities. So like right now, we have 6 major priorities and people can find that on the DSHS website and they will find the Texas state plan. So within that plan, we address those key priorities that we know will affect Texans with diabetes by recommending and advising the legislature on solutions. And we've been so fortunate. The Texas Diabetes Council is 38 years old, so it was instituted in 1983. So the council has lots and lots of opportunities to advise, and fortunate that the legislature does take our advice, right? And that's the good thing. And so in this 87th legislature that just closed out, we were fortunate because of past actions 5 years ago. So everything kind of builds upon each other. We were fortunate to have at least 7 diabetes-related bills passed by the Texas legislature. So I don't know if people know about it. And one of those, we have Senate Bill 827, which is also HB 82. It caps insulin copays. That is a huge, huge win for Texans with diabetes. And that took 5 years ago, council members working every odd number of years with those state plans, keeping up with our legislators to let them know how important these bills are. Because we are talking about how to solve these disparities within our communities. Heavily, 95% of them depends on policies. And you have policy, whether it's in healthcare, whether it's in education, whether it's in employment, anything you can think about, those policies matter. And so being able to have diabetes-related bills, and that's just one of them. Then we have HB 18, which is Prescription Drug Savings Program. Those are great. And the big one that almost everybody will say hallelujah to, HB4, the tech-related healthcare services that allows telemedicine, telehealth, that, the pandemic brought all that. But because of that bill, we see great advancement. So there's several major ones. So this is how we do our work. And our council members are constantly working, not just when the legislature is in session, but when they're not in session. So now in the next 2 years, they're going to be off, but the council is not off. The council is still hard at work, ensuring those key areas of our priorities, that we are building momentum, that we're solving those things. We are addressing one of the key challenges right now, which is diabetes education awareness, making sure that these related bills that were passed, people actually know of them, right?
Mhm.
If you don't know of them, how are you going to make use of them? You won't be able to make use of them. So we want to make sure that the result of our work actually gets to the people that actually need them. And that's for our people within our communities. So that's how we do our work in the council.
Very good. Very exciting. That is a congratulatory type of praise that needs to go out there. 7 bills being passed. So great work. We're excited about that and moving forward and getting that word out there. Ooh, I was excited about that.
Yes.
Our next question is, why has it taken so long for disparities in care to be addressed by healthcare providers and the system overall? Why is it taking so long?
Yeah, I can take that right on. I'm going to be spelling it out. It's systemic racism. I've been discussing health disparities for over 30 years, but it took a virus and the killing of George Floyd for the country to come to grips with the term, with even healthcare disparities, because for many they didn't think it was a problem, and those of us who were part of that system, we knew that the system was broken. And instead of window dressing, instead of bandaging the situation, we need to have a concerted effort, change the status quo, period. I believe that before 2020, there have been a lot of representation, and that of incorporating the voices and services of our grassroots organizations and faith-based ministries and community health workers. But for many years, the money went to the institutions, and the institutions that went racing toward the funding, and once they got the funding, they came back to the community partners to help, but they weren't paying them, or they were paying them really late, and that caused more mistrust. And so the saga continues, and until we really make a concerted effort to acknowledge the invaluable service of our community and our patients, that even our diabetic patients and caregivers, the people that have already have full knowledge of the disease and all the things that they have had to deal with, those are the key people that are the best educators. And getting that message out is what we need to do, is getting the message out and teaching our healthcare providers.
And I'll add to that layer, three key things. Number one, we have limited knowledge of what the needs are within our communities. And so that's why we need every kind of representation. Any table, anywhere needs a diverse representation, because you're not going to know the needs of the community if you don't have representation. So you can have people, boots on the ground, doing the work. However, where those key discussions are taking place, we need a diverse representation. So that's one, limited knowledge. Secondly is cultural barriers. We've talked about it a lot. And the cultural barrier ensuring, for example, one of our council members just sent me something today, and I was really excited. And we're looking forward to having that organization. They're part of the National Health Information System. And we're looking forward to having them in our upcoming council meeting next year. What did she send me? She sent me a farm workers health care referral service. And one thing caught my attention there: provider translation services. Why is that there? To break down the cultural barriers. And so things like that are really, really important. And then the third one, we talk about system. Why is it taking long to address this thing, healthcare provider or within our system? Systems are made of humans, right? And humans are flawed. And that means our systems are flawed. If we can understand that, I think it will help all of us to work together more cohesively in ensuring that the systems actually deliver what they were meant to do. And also the systems, because is 99.5 government, right? and we have the private sector coming in, but our major system, the government system is a wheel that goes extremely slow. If we understand that, we look at how we can work together to break the red tape. And that's why I love what the council does. The council is there to help break the red tape for Texans with diabetes. We do the work and we get to places that people cannot get to, provide the actual data from actual people, and make sure that even with our own administrative agency, the DSHS, we also have partnership with other governmental agencies, ensuring we get to work for the communities that actually need them. So these key three things are so big when it comes to addressing why it's been so long or so slow. Yes, we have to recognize what we're working with, because when you recognize what you're working with, that's half the battle. When you don't recognize what you're working with, you're just spinning and spinning, no results, and we don't want that.
Very good. The system is built with people, humans. They're built to hold us down. So very good information. So enthusiastic and overflowing here. Exciting. What do Blacks and Latinos need to do a better job of managing and monitoring their diabetes and health overall? What would you say those major tips are that you would give?
I will give you some major tips that we've discussed in the council, and that also working with a lot of healthcare providers. The need to access in terms of economic stability. It comes back to social determinants, of health when we look at the overall. But need to access economic stability is one of those things. For example, if you have within our communities, families that have been affected, by the pandemic rear-ended a lot of people. They lost their homes, they lost their apartments, they couldn't make payments and those things. It adds more stress. And research shows us medically, we know that stress upon stress upon stress. We have good stress, we have bad stress. Compound those bad stress and you have a health problem. You have a health challenge.
Mm-hmm.
So the ability for economic stability is one. Also, accurate education. And Venom Sam shared that earlier. That is so important for us to have accurate information, breaking down all these medical terms that are intimidating, not just to our communities, but to people in general, and breaking that out. And also the big one we've said, diabetes happens because of the food, right? That is transferred into energy, and then something happens, a breakdown within the body system. Access to healthy food. You said it so well, Dr. Myers. Healthy food does cost money. It does. Now, back in the day, I don't know how many people, I guess I'll be giving my age out here, right? Back in the day, you could get a gallon of Oak Farm dairy milk, and for like 50 cents, and that was it. And you could get that. Well, back then, we didn't have much diversity in terms of milk. And everyone, like in our area, Oak Farm Dairy were the big thing. Now, medical professionals are telling you, no, don't do Oak Farm Dairy. Don't do, the 1% or the 2%. It's not good for your health. We want you to do non-fat. We want you to do almond milk. We want you to do coconut milk. We want you to do goat milk. Well, have you visited the grocery stores to see how much those are? Your almond milk, your goat milk, your skim milk are double the price of your whole milk that, laid it in fat or whatever you want to call it. But that is the key thing. Access to healthy food is key. It's important to ensuring that we do a better job of managing our health and taking that personal responsibility. And we're doing that through this summit. We're empowering people to take personal responsibility of their health, showing up for ourselves, showing up for our communities, that this needs to happen and we need to do this. And know that I know you don't want to go to the doctor for annual checkup. Can we go as a group? Can we have group physicals within our communities to lower that fear, to lower that affective filter? of not wanting to go. Can we do that? Yes, showing up for ourselves. These key things are important. Ensuring that our people can manage their health, especially diabetes, very well.
Very good. Very good.
So
Ginés, did you have?
to add,
Okay.
yeah, to add that, I mean, this is incredible, but it's exactly how I feel. Three
Mhm.
things come to my mind: accessibility, affordability, and accountability. Accessibility: many of our people don't have access, like the doctor said, to really nutritious foods. And the cost of the food right now is just unbelievably high. And I've said it before, many of our Latino families are large families, so they have to really feed a lot of folks. So we tend to go to the processed foods or the rice and the mac and cheese, and that's like a staple for many of us now. I mean, you can make feed a lot of mouths with just something like that, the pasta, and so this is some of the things that that we are concerned about, is the fact that a lot of the food plans are for foods that people in the United States eat. They're comfortable, the mashed potatoes and stuff, but they don't do anything about our foods, so they don't take into account those of us who are from a different culture, the foods that are our staples. And we still don't have that understanding of how to tailor some of that and make it more nutritious. So even something like, spaghetti, having ground turkey instead of ground beef, that makes a big difference. It took me a long time to get that out to our community, or tacos, and making sure that that meat is not ground beef or with all the grease, but to use ground turkey and really season it well. So it's the way you present it, but it's something that we haven't talked a little bit too much about, and it's part of the social determinants of health, is the accessibility to getting to a medical provider or a program so they can get on a management plan. And the people that are managing those plans, the people that are heading, many of them don't understand the language or the culture. So those, we need to have more folks in that area. When it comes, and I already said about the affordability is a real issue with us as well. And accountability is the fact that we seem to always try to blame, the culture. You should, again, going back to what I said earlier, the Latinos should be doing this, they shouldn't be eating this, and the African American community, they eat too many fat foods and fatty dishes and stuff like that. It's our culture. So help us, instead of blaming us and putting us in a box.
Mhm.
Help us have people
Mhm.
that look like us, and give them the tools of what we have currently, and then say, how can you tailor that to be culturally and linguistically appropriate for your community? That's also one more thing. The streets, they say walk. Well, some of us can't walk in our neighborhoods, right? I mean, some neighborhoods are not safe for people to walk around, and
Yeah.
so again, even now more than ever. So many of our folks in our community live in these kind of neighborhoods that it's not safe to walk. So there's a lot of things that go into managing your diabetes that, we could take a few hours to talk about that.
Mhm. Very good. I like the conversation about culture and seeing people that look like me. I'm probably I'll probably do what they're saying to do if I could say that, oh, she's doing the same thing, so that it thinks about things that make me feel good. When I have a spiritual relationship, I go to church because it's people that look like me. I can worship with people that look like me. I'm comfortable there. So bringing that conversation to this next question, do you think family and friends can play a bigger role in influencing those who struggle with chronic conditions? And then part two is, how would you suggest they do that?
Yes, they do. It's called support. And if anything taught us anything, I think the pandemic taught us that, right?
Yes.
How
Yes.
important that is. And one of the ways to do that is to communicate your needs. You have friends, you have family. If you don't communicate your needs, they will not know you have a need. Letting them know, and many times it takes being transparent and being vulnerable and say, hey, this is where I am. I have this need. Hey, last week I went to the doctor. This is what the doctor said. And knowing that your family and your friends are your primary support system, and asking for that help and communicating the help, it's crucial. Because they will only know what you've communicated to them. If you don't communicate to them what the needs are, they don't know. That with every way our schedules are, as humans, especially here in the States, it takes a lot. So knowing that your family and your friends are your basic support system, communicate the needs that you have. Let them know. If you already know a specific way that you need their help, you let them know. And that's what community is all about. And it starts right there from those key support system of family and friends.
Yes,
I
very
can't
good.
say enough about social support. But here's something that's serious with us in our community is the sharing of insulin needles. I mean, that is something because of the cost. Again, going back to the
Mm.
affordability, a lot of them don't have the funds for their medication. And so what they do is they start sharing some of that medication. Here, I'll go ahead and cut this pill in half. I will prolong it, so I'll just cut it in half for me. Or somebody needs it here. I'll share this bottle with you. Let's share the pills. I mean, these are the kinds of things that we have seen in our community that's very dangerous, but they don't have the understanding that they think, oh, this medication is for diabetes. It's for diabetes. So I have diabetes. I can take this medication, but they don't realize that some diabetes medication is specific to that patient and not to everyone. And so getting that information to our community is key. But who can do that? Our promotores and community health workers, and that's what we're trying on our end to do.
Excellent. And don't forget, we have HB 82 that caps insulin copay. We have HB 18, prescription drug savings program. This is why those legislation are so important for our communities to know and to be able to utilize that. They're very, very important. And people can find out more about them on the DSHS website and just go to Texas Diabetes Council. There they find those. We need to get this information to our communities.
Yeah, very good. I was just going to ask, how do we have access to that type of information and
It's good.
being able to expose that to our guests? Question: Are minority communities any more or less willing than non-minority communities to embrace new technologies aimed at healthy living? I think about the patient portal, and those kind of things, the new technology these days. So is it a little
Um,
differently?
I'm glad you brought up the patient portal. So, those are probably making like their 7-year anniversary on the scene, and every single one, from your email to all the other things, work emails, your access, they have health portal to monitor and to monitor your health, get your results, and all that. Sometimes it takes a lot because sometimes the portals are not user friendly, especially
Right.
if you're setting up for the first time. And then you cannot easily get someone in the office, there to say, hey, how do I do this? You send that email, it comes back the next day, you've already forgotten that you even tried to log into the portal. Right. Then we talk about our diabetes, patients also having, glucose monitoring devices that are user friendly. I believe strongly that they are willing, so long as it's user friendly. And everyone can say yes to that. If it's user friendly and it's easy to understand, everyone will be more than willing to embrace that. So this goes back to product development within our manufacturing organizations that address, healthcare needs, especially with diabetes, ensuring that they actually meet with people within our communities to really assess their needs. We had one time we had a company that produces devices. The council, we basically do not promote one organization or the other. We basically, our intent is to make sure we provide the education awareness needed for Texans to live a successful life, even with diabetes, managing that well. So they finished sharing about, the device and everything. Well, it comes to the point that the device is about $700. And I have to be honest on that. A lot of people don't in our communities don't have $700 to buy a device. Let's be
Right.
honest, they don't. And so I asked the question. I said, by the way, how many people within underserved communities did you visit with to assess their needs? And the answer was, we're yet to do that. Well, if you're yet to do that, you are not providing, technology devices to help the underserved communities. You have to visit with them, assess those needs, and see and let that come into the planning and design stage of your devices. But a 700 device, a lot of people cannot afford that. For a lot of people, that's even their wage for the week to take care of their families. So ensuring they're more willing to use any device so long as it's user friendly and is easy to understand and the cost is affordable to an average person, no matter who they are, whether they're Latino, African Americans, or Caucasian, no matter who they are. But if you have a device that is $700, a lot of people within our communities are going to kind of weigh the risk. Do I feed my children today? Do I get this device? Do I do this? Do I get this device? So we have to be cognizant of that.
Yeah.
And to add to that, some of them don't even have an email. So they couldn't even get to start their application to get into a patient portal without an email. So we have had to go back and try to get them an email. And then, like you said, they forget their password. So we have to try to work it out so they'll remember where to put their password on their phone. So it's a lot of training and a lot of patience. That's why our organizations launched the Telehealth Community Navigation Center. It is a contact center where we have a nurse navigator who's bilingual. We have somebody who's monolingual who's just a darling. She's a promotora. She's just really sweet. And then we have somebody who answers the phone who's bilingual. And the reason we have that phone is because a lot of people can talk on the phone. They can text and they have learned how to text. So we are now texting information to them, advice to them. They send us, that all this is on an online platform, a cloud-based platform that we have. It's with it's HIPAA compliant, and our community health workers are the ones that are really staffing this. And so again, going back to making it accessible for them, if they need help with navigating them to even a vaccine site or navigating them to make an appointment to see their doctor for whatever reason, we can do that and we can speak the language and but like you said, it is a training, especially if they don't understand how to, and they don't have the means to. It's understanding how to use the device, how to get an email, and then how to navigate through that complicated system of getting into a patient portal. And the first time I did telehealth, and I'm college educated, I was having a difficult time. You too, right?
I totally attest to that. And my research is with the elderly population, and just simply me, myself, remembering passwords, remembering how you have to maybe add one number to it. You have so many characters that you have to put in. You have to do some colons and then capital letters and then lowercase. And then to ask someone to remember all of those things, like really, I think about systemic racism, like it's built into the system for us not to understand in some time, those ways. The cognitive capacity, as you get older, that working memory declines often. So really to share with them where to put your passwords, and then for them to remember, where did she tell me to put my password? And then who do I trust to come tell me where I put that password? So it's just a trail that you have to be ready to have support systems to really walk you through those processes. And it becomes remote memory to remember, this is what we did the last time. This is where I wrote it. Here's that little piece of paper or that pad that I had that I wrote these instructions down. Oh, this is what she told me to do. I'm going to try to do exactly what she said. So really taking all of those concerns into account when we're thinking about this patient portal. Like I say, I run from it in ways. It's like I want to speak to a human person. So it's kind of tough in the technology age that we're in now. But that can be another conversation or summit. We're moving on. We're coming up to an end here, but what is the solution of providing healthy? I think we kind of talked about this. What is the solution for providing healthy foods to communities that lack supermarkets and grocery stores? I think we kind of looked at that a little bit.
We did, and I'm just going to say three things to that. Number one is investment. We need investors that are willing to take that heavy risk in investing in building supermarkets, grocery stores that stocks healthy food. We need those. During the pandemic, you saw that our communities were heavily affected, right? So that takes me to the second one, partnerships. Being able to leverage what we do individually as an organization and coming together in bringing that to our communities is crucial. And that takes me to the third one, food distribution. So I'm going to put a plug in right now for North Texas Food Bank because our organization, not TDC, that I have the opportunity to serve. However, our nonprofit organization has partnered with North Texas Food Bank in distributing food for the holidays, Thanksgiving, Christmas, and making it a continuous process, even for next year. It's important that we do that. And that's one of the ways, not Texas Food Bank, and I know every major city, whether that's Austin, whether that's Houston, whether that's San Antonio, whether that's Corpus Christi, every major city in our state does have a strong food bank. Linking up with them and ensuring it takes a lot of work, but at the end of the day, we're saving families. We're ensuring that our kids have nutritious food because that's one thing the North Texas Food Bank does. They ensure that every food that is distributed are healthy because that is the key thing. And they are focused on food deserts. So those three ways we can add them to some of the things we've already discussed in ensuring that in our communities, we do have healthy food available to all.
And the only thing I want to add to that is my wish is that we had more farmers market everywhere
Oh, yeah.
because that's community based. That is something
Yes.
that people will bring together. It would be an opportunity for people to have that moment of understanding about what diabetes is or some of these other hypertension or heart disease, is having these community events where we have the farmers market, we invest in our farmers and getting the food out there that's fresh. And then, as you stated, the food bank. We need to start supporting our food banks because they helped us several times when we've had our events, and people would just line up just to get the food that they were offering. But sometimes that, especially now with the food, with the increase of the food right now, that they're going to be in trouble. They're going to need a lot of our support. So invest in those food banks, and let's start creating more farmers market in our communities.
Yeah, the word community came to my mind. You think of fellowship, community, coming together in those circles to where you're able to then have community with those who are like minded and we're moving toward the same goal. Now, this next question is for you, Venus. Now, we've kind of talked a little bit about it. You mentioned the health fiesta events, and you're the pioneer of these events. How are you using those events in ways to showcase healthy lifestyles?
So in our health fiestas, we actually provide those early detection screenings. So our goal is to really bring those screenings to them. And the people that are actually conducting those screenings are people that they look like them. And so it's very community. We've got music, we have the environment there, we have activities for kids. Our health fiesta is a fiesta. So we have our
Nice.
promotores and community health workers who have already been trained on how to do diabetes, glucose screening, vision screening, blood pressures. So when we offer that in these mini health fiestas, people will come. And my whole idea about the whole vaccine, if they had come to us, we could have said, let's do these mini health fiestas. Let's give them something that they can actually take back home and say, oh, I stood for 3 hours for a vaccine, but I did get a glucose screening and I found out I had a high glucose or something like that. It is our way of really bringing these services to them in a way that it's very culturally tailored. And we're very proud of that. And then, of course, I can't say enough about the incredible role of community health workers and promotores. I mean, I am so glad that they, again, like I said, being recognized for their role in dispelling myths and bringing good information to our community. But more importantly, they're able to navigate. They are the best community navigators.
Very good. Thank you so much for that. Now, this next question, Dr. Obamehinti. How are our faith-based communities embracing health challenges in these communities, and how can we do better?
I love that question. I love it like 100 times because faith is the central focus of my life. It's very dear to me. For when we talk about African American communities or our Latino communities, faith is like the central glue that holds our lives together. And
Yeah.
so, places of worship are just not places of worship, but they are places of information, of empowerment, of education about different things. Whether you want to be educated about the education system, you're looking for something. It's basically like the hub. And I've seen our faith community since last year, especially. And that's because last year was a defining moment for the entire world. And into this year, still continuing to some point, but I've seen the faith community rise up in changing the conversation.
Very good.
Change the conversation. And I love that because if we're going to reach people where they are, we need to change the conversation. We need to be right where they are. So I saw that now we no longer look down on people and say, oh, they don't have faith. That's why they have that. Because as a faith community, we're actually a spiritual hospital. That's what we are. We're a spiritual healthcare hospital where people can come, and research shows amazingly. The Bama research group did research, and people of faith that had a faith to fall back on did way, way better from last year into this year. And they found that out because it was more like an anchor for them. That even though everything around them was shaking and uncertain, but they were certain about where their hope and their trust was. And so that's important. The conversation changed. Another thing that the faith-based communities have done in embracing health challenges is you see that faith leaders are becoming more becoming transparent on sharing their own life story, bringing their own life story and realizing we cannot separate our life story from the message of hope or the message of Jesus Christ. I'm sorry, you can tell that I am fired up about this. But they're doing that because they want people to know that, hey, okay, they have health challenges. It's okay. We're not saying that, oh, because you have faith, it means that everything is just, rosy. It means that despite all of that, your faith anchors you and holds you. And your faith enables you to see the purpose of life and the meaning of life. So the conversation have changed. Faith leaders are becoming more transparent about their own health challenges. We're seeing that. And more also, we see that a lot of faith places have hosted a lot of community forums, whether that's online, whether that's in person, they're doing more of that. For example, when it became a huge, huge challenge within African American communities to get people to go get vaccinated, are people because they didn't want to. And you can't blame them in the sense that there's so many things that we have to look at. You have to look at the historical context of why are they hesitant to do that. A lot of our faith places rose up to the challenge. They had community sessions. They brought in medical doctors. They brought in healthcare providers, and to basically explain the entire process. You'll be amazed how explaining things in a childlike language that anyone can understand. Einstein said if you cannot explain something in just a simple way, then you don't know it at all, right? But being able to explain to our communities that this is what it is, this is what it is, these are the choices that we have, it will actually help you on the long run. Or if you have health conditions, these are also other health options that you can do. Our faith community has risen up to that, changing the conversation, faith leaders sharing their own struggles and being transparent, realizing they can separate that from the message of hope, and also holding those health forums to explain within our communities. How can we do better? Well, Venus is doing something that can help us within the faith community to do better. I say two things to help us do better. Not every places of worship have what they call a medical ministry. And a medical ministry, and it doesn't matter whether we're talking about African American, our Black churches, or our Latino churches, or Caucasian churches, or non-denominational that brings everybody together. It doesn't matter at all whether that is. A medical ministry is important. And in the medical ministry, you just don't only have doctors and nurses, but also maybe people that are interested in health, being a part of that, paramedics and things like that, that it becomes viable, a viable entity within that faith place where everybody knows that, guess what? If during service something happens, this is the medical ministry, they're there, we need that. Another thing that we can do better is what Venus is already doing, organizing health fairs. A lot of our people will not go for annual check. However, if my church has a health fair, I'm going. I'm going to the health fair of my church, right? Like you said, the place of fellowship, the place where they have that sense of purpose together in their spiritual lives. They will go. During the health fair, we can have vision tests. You'll be amazed how many people, simple as a vision glasses. I was talking to a lady the other day, and she's like, oh, the last time I got a new glasses was like 7 years ago. I'm like, wow, 7 years ago? That's a long time. Because those eyeglasses will give you migraine headaches. They're not supposed to, 1 to 2 years, but 7, that's a long time. So we have eye screening, we have dental check. You'd be amazed how many people have not gone to see a dentist, to just have that cleaning. Having that. Also, having their BMI checked. That you have those stations. So you feel like you have stations, people go from one to the other. Mammograms. How many of our women, they've not had a mammogram in years, because they don't want to go. But if my church has it, physicals, how about physicals? The young ones, for the adults. Here in our area, we normally have what they call the Mayor Back to School Fair. And the Mayor Back to School Fairs brings in everybody to prepare our kids for the new school year. Health, you have healthcare providers. You have barbers that are there to, help with the hair. You have eye, exams. You have, dentists. You have blood work. You have all that. We can do that because a lot of our people, their place of faith is their main hub of being empowered. We can do better as faith communities.
Very, very good. Thank you so much for that. And right now we're going to finish up our time and we're going to ask Venus to give us our final thoughts and then we'll end. Thank you so much.
Yes. So finally, what I wanted to share with you is that we're starting a campaign. It's called No Mas, No More. Misinformation plus miscommunication equals mistrust. And we are banding together with our African American community and our brothers and sisters. We're going to need to start joining efforts to start erasing some of that systemic racism, because it's going to take us to do that. And we're going to do that. That's why we say no mas, no more. You're not going to do this to us anymore. We are armed with the education that we need to have in our community, the empowerment, body, mind, and spirit, the spirit. And that's what I want to say is just that we're going to throughout all this with spirit. So thank you so much for the invitation. God bless you. Adios.
Very good. Adios. Bye-bye. Thank you all so much. It was great.
Okay, bye-bye.
Bye-bye.